Welcome back. Well, we've been talking about additional investigations in differential diagnosis, therapeutic options and risk reduction, smoking cessation, surgical treatments, and other medication treatments. So really, if we start with how do we manage stable COPD, what are our goals of therapy, how can we avoid risk, what pharmacologic therapy can we intervene with, and non-pharmacologic therapy such as exercise, how can we manage exacerbations, and what are their consequences when you have a worsening of disease? How can we assess that? How can we treat that? So really the main thing is identification and reduction of exposure to risk factors. We got to get away from cigarette smoke. We have to watch exposure to infection. And if we're going to prevent and treat, that's really going to be the cornerstone. So if we take a look at individuals, you have to look at your own life. You can't just be looking at a computer screen and have it suggest exactly what you do. We need to know where you're going to be. We also need to take a look at what causes your airflow limitation, what causes that contraction, and we want to make sure that we're getting a step ahead of these exacerbations. And with this grant, the idea is to do that with case management and these community health workers. Everybody will benefit from rehabilitation, maintaining physical activity, and we use the pharmacologic therapy really to reduce symptoms, reduce the frequency and severity of these exacerbations, and really improve overall health status and your ability to tolerate exercise. So to do that again, the long-acting beta-2 agonists, the ones that relax your lungs for 12 hours, the cholinergics, the anticholinergics, again, not causing the lung to contract. We prefer those over the short ones. So people you see sucking on their inhalers all the time, really we have alternatives where they don't need to do that. For some people it's a placebo. Well, we don't want a placebo. We want medication that works, and we want it to work for your life. And so taking it twice a day is better than depending on that short acting where if you've lost it, oh my gosh, you're going to be in real trouble. So if there's a high risk of exacerbations, we want these long-acting medications. Now, long-acting therapy just using the steroids by mouth is not recommended. Just using an inhaled steroid without that medication to open up the bronchial tubes is not recommended. And again, that roflumilast, the phosphodiesterase 4 inhibitor, if you're down there with the ability to move air through your lungs at less than 50%, you've got chronic bronchitis, it can be very helpful in terms of those with frequent exacerbations or worsenings. So really what we're looking at, we want to reduce symptoms and reduce risk. We want to relieve symptoms, improve exercise tolerance, improve health status. We want to prevent this disease from progressing. I can't make it better, but I can prevent it from progressing. I can make your symptoms better, I can reduce them. And then we want to get a very early prevention and treatment of exacerbations or worsening. And we want to prevent death. We want to have a good life. We want to prevent death. And by making these interventions, we can reduce mortality. So, avoiding risk factors, smoking, indoor pollution, occupational exposure, get your influenza vaccination, and your pneumococcal vaccination as well. So when we look at the non-pharmacologic interventions, again, smoking cessation, physical activity, flu vaccination, pneumococcal for mild disease, really that's what your doctor is going to be recommending. As we move into the worst patient group, if you remember our little chart from before, patients who are having problems with breathlessness, who are having exacerbations, smoking cessation, big part of it, physical activity, a big part of it, flu vaccination, big part of it, pneumococcal vaccination, big part of it, pulmonary rehabilitation, but we really need to include the medication on a chronic basis, long-acting medications that fit in your life. So if we take a look at the different types of medications, the antimuscarinic short-acting, the short-acting beta agonists, those are really for just symptoms, and so when people have mild disease, they may be sufficient. As we move into that category B where it's beginning to affect your life, now we really want to start looking at long-acting muscarinic antagonists. We want to look at long-acting beta agonists and combining them with the steroids. As we move into those people who are having exacerbations, bringing up sputum, FEV1 is less than 50%. Now we need to be doing that very aggressive pharmacotherapy, and we have alternatives, and this is where it's time to meet with your pulmonologist and really look at more and more combined medications. As we hit D, the ones at higher risk, then that inhaled corticosteroid plus the long-acting beta agonist and a long-acting muscarinic antagonist is essential therapy. There are alternative options, but really these are the things we need to introduce into your life. So again, we're looking at symptoms. If your symptoms are at a combined scale of less than 10, your feeling of breathlessness is 0 to 1, you're in pretty mild disease, and as you see on the screen, these are the therapies that are recommended. Now, these are the alternative choices as well, so that if your insurance company or the formulary doesn't cover the exact medications that fit in those categories, these are some alternatives. And for some people, it's a matter of, well, we had one medication that worked very, very well, but it tasted like licking a car bumper. And so we complained to the manufacturer, and they put mint in it. So now it tasted like a mint-flavored car bumper. So some of these medicines, they may be hard to take, may not taste right, and so we need to look at these alternatives as well. Other possible treatments, again, especially as we move to other countries, we may be stuck with a very limited set of medications, and so we start looking at these alternatives, the carbocysteine and short-acting beta agonists, theophylline, because we are so limited in the medications available. The expense to the government as they try and treat these people with a very damaged economy, much like we'll see in the Honduras and Nicaragua. For them, there's a very limited set of medications.